In this episode, I interview Professor James Lindsay about inflammatory bowel disease. If you enjoy this podcast, please like and subscribe. I'm Dr. Gail Busby, and this is I Forgot to Ask the Doctor. Hi everyone, thank you for tuning into the show. On this episode, I'm going to interview Professor James Lindsay about inflammatory bowel disease. James is a consultant gastroenterologist and professor of inflammatory bowel disease. He runs an adolescent and adult service. He also contributes to the British Society of Gastroenterology IBD Clinical Trials Steering Group. He is extensively published in this area and therefore well placed to educate us today. I'm delighted to have him on the show. James, welcome. Thank you so much for agreeing to be interviewed.
And thank you very much indeed for inviting me.
So, James, I find it fascinating to find out why distinguished colleagues like yourself chose the particular area of medicine in which to practice. So, can you enlighten us as to why you chose to work in the field of inflammatory bowel disease?
Absolutely. I think there are several reasons, really. Initially, my interest was academic. My background was in medicine, but in science. I did a PhD in the immunology, the immune functioning of the gut. And because inflammatory bowel disease is one of the most common diseases where dysregulation and upset within the immune system of the gut causes disease, it was an obvious area of interest. But I think more recently, my interest has really been in the fact that it's such a rewarding area to work in because of what we can do for patients. The conditions, Crohn's disease, ulcerative colitis, the two inflammatory bowel diseases, cause a huge burden of symptoms for our patients. And they're really quite sort of unpleasant because they all involve the gut and the toilet and the tummy and smells and things like that. And so they understandably cause a big impact on patients' life. And we can really help them. We can make a difference. The patients that are affected often are young people, often trying to get on with their lives, be it studies, be it exams, be it having a family, be it work, and we can make a difference. And that is incredibly rewarding. I think the other thing that I love about working in this area is it's an area of medicine where we've really worked hard to build up a wide-ranging team of different professionals to help patients. So, in my clinic, we have doctors, we have dietitians, we have a psychologist, we have a pharmacist, as well as surgeons and regular. So it is nice team working. There's a whole team of us together trying to help people.
Yeah, that's a great answer. Thank you. So, James, as you know, this podcast is aimed at educating patients. And for that reason, we try to avoid using medical terminology as far as possible in order that it remains as accessible as possible to everyone. So let's start at the very basics. What exactly is inflammatory bowel disease, and are there different types?
Yeah. So inflammatory bowel disease occurs when the immune system, the immune cells, the cells that are there in your gut to help fight off infection, when those cells, rather than sitting there being happy and tolerating the large amount of bacteria and food in your gut, for whatever reason, those immune cells start reacting to the normal, the healthy gut bacteria. And when they start reacting to the bacteria, they cause inflammation, and that inflammation causes swelling and irritation of the lining of the gut, which leads to the classic symptoms, which are loose stool, blood in the stool, tummy pain, weight loss, and fatigue. And so the condition occurs because of a reaction to the normal contents of the gut. There are two types. You asked, are there two different types? There are two types. There's ulcerative colitis, and that's where the inflammation is limited to the large bowel, the colon. And because it's limited to the large bowel, its symptoms are almost always diarrhea, urgency to go for a poo, and blood loss when you go for a poo. And then there's a second type, and that's called Crohn's disease, named after the person actually who discovered it, but it's called Crohn's disease. And that is a slightly different type of inflammation. It can occur anywhere. So it can occur in the colon, in the small bowel, in the stomach, in the gullet, in the mouth. It can also occur around the bottom, around your anus, the bottom itself, or even sometimes in the vagina in women. So that can cause a whole range of different symptoms depending a little bit on where it's based.
Okay, that's really interesting. So I always ask about risk factors because with certain conditions, there are risk factors that are identifiable. There are some that are difficult or impossible to change, like your genetic makeup, for example. But
Yeah.
sometimes there are lifestyle factors that can reduce people's vulnerability of developing a certain condition or maybe mitigate the severity of the condition. So, are there any risk factors for inflammatory bowel disease? Is there, and is there anything that people can do to minimize the risk of getting it?
Absolutely. And the simple answer to that is yes. The more complicated answer depends on an understanding of what causes the disease. And so, I think of that gut reaction to the bacteria, that is partly initiated by a genetic susceptibility, your family, the inheritance of genes from your family. It's partly that, but it also often occurs after some form of change in your environment. So there are environmental triggers for the disease. The biggest risk factor, sadly, is something you can't do anything about, and that's having a family member with the disease. And obviously, you can't change that because you either have or you haven't. The second and most widely known risk factor for Crohn's disease is smoking. So if you want to avoid getting Crohn's disease, stopping smoking is the best thing you can do. And also, if you've got Crohn's disease, stopping smoking is a really good thing to do, because people with Crohn's who smoke have worse disease, they respond less well to medicine, they're more likely to need an operation, and the disease is more likely to come back after an operation compared to non-smokers. So quitting smoking for Crohn's is the best thing you can do. Somewhat paradoxically, smoking is protective against ulcerative colitis. So if you smoke, you're less likely to get ulcerative colitis, but that doesn't mean we encourage our patients to smoke. Definitely does not mean that. Then other risk factors. So gut infections. Often, if you look at people who develop the disease, if you look back at the preceding few months of their life, often they'll have had a gut infection, or they might have needed to use antibiotics. So gut infections and antibiotics are risk factors for developing the disease, as are taking anti-inflammatory drugs like ibuprofen, Nurofen, drugs like that, because what they do is they make the gut a bit more leaky. They allow more contact between the normal gut bacteria and those immune cells. And if you're at risk of developing it and you suddenly bring the two together, then you can develop it. So avoiding taking ibuprofen and Nurofen is a really good thing. Diet is one of the really fascinating factors about inflammatory bowel disease. It's highly, highly, highly likely that aspects of the diet, particularly what might be called a sort of westernized diet, increase the risk of developing particularly Crohn's disease, less so ulcerative colitis. And one of the factors that sort of makes us think that is that whereas the disease incidence, the frequency that people develop the disease, is relatively stable in Europe and America, it's rapidly increasing in countries where their traditional diets have become more Western over time. Exactly what it is within the diet is actually much harder to be clear about, but it's likely that aspects of food processing, food additives, food emulsifiers are factors that are associated with an increased risk. Then there are some protective things. Being breastfed is protective. Obviously, not much you can do about that when you're an adult, but if you are having kids and you're worried about Crohn's disease, breastfeeding is protective.
Yeah. It's valuable. Wow, that's amazing. Really, really valuable information. And you touched a bit in the introduction about the symptoms. Can
Mm.
you just clarify for us what the symptoms are? Are they, I guess there's some in common, obviously, um,
Between the two diseases.
between the
Yeah,
two diseases. But what can you give us like the range of symptoms? So what symptoms can a patient have that they might think, oh, they might listen to this podcast and say, I've got this and this. Maybe I have inflammatory bowel disease. I'll go along
absolutely.
and see my doctor.
So they're gut symptoms, obviously,
Mhm,
because they're gut conditions. So
mhm,
that's loose stool, diarrhea, going more
mhm,
frequently than often for a poo, having to rush to
mhm,
the toilet, getting
mhm,
up at night to go to the toilet, and passing blood. And they're probably the most common symptoms. People with Crohn's and some people with ulcerative colitis get a sort of crampy type tummy pain. People might get more frequent mouth ulcers. People might be losing weight, particularly if their disease is very severe and they cut down on how much they eat. Some people develop abscesses, boils on their bottom, and that's particularly associated with developing Crohn's disease. Often people have fatigue, and that's partly because of the disease and partly because they become anemic. Their blood becomes too thin because they're bleeding.
mhm,
And then there are some symptoms that occur outside the gut, some swollen joints, sort of joint pain, some inflammatory sore skin rashes or skin ulceration, and some inflammatory eye conditions where you get a red, painful eye. Now, one of the problems is that many of those symptoms are very similar to the sort of symptoms you get with IBS. Not all of them, but some of them. So, loose stool, tummy pain, bloating, fatigue, they all occur in IBS
yeah.
as well as in IBD. Now, it's really confusing because you've got IBS,
Yes.
IBD. They sound so
Yes.
similar, but they are completely different. So,
Different. Yes.
IBD, an immune reaction against the bacteria in the gut causing gut inflammation. IBS is a disconnect in the normal functioning of the gut, so that you've got issues with gut motility, issues with the sensation of the gut feeling pain, and issues with the way that the bacteria ferment food, causing bloating. Very different conditions.
Okay.
I guess if
And
you said to say what are the conditions that differentiate, well, bleeding is one, weight loss would be another, having to get up at night to go for a poo is a third. But realistically, there are some quite straightforward things you can do if you're worried that help distinguish between the two.
okay. And just to clarify, I'm interested to know the symptoms that aren't directly related to the bowel, like the skin symptoms, the eye symptoms that you
Mm.
mentioned. Can they happen in isolation without the bowel symptoms?
Yes, I mean they can. So for example, there are some very classic skin rashes that if you saw someone having, you think, oh, I'm going to have a look at their bowel to make sure they don't have inflammatory bowel disease underneath. There's a very a rare liver condition where the liver ducts become very inflamed and people get liver disease, and it would be almost always associated with the subsequent inflammatory bowel disease, even if the liver diagnosis comes before the
Mm-hmm.
IBD diagnosis.
All right. Okay. So it's a multi-system condition, really, not
Yes,
just limited to
yes,
the
it's not
gut.
just the gut.
Yeah. Okay. And if someone does have these symptoms that you mentioned, how urgent is it recommended that they go along to see their doctor? Does it make any difference whether they kind of soldier on for months or years or whether they go to see the doctor immediately? Does earlier diagnosis have a better outcome, is what I'm asking.
Definitely.
Okay.
Definitely. But there is a slight caveat to that because, of course, because another cause of all those symptoms would be a simple gastroenteritis or food poisoning. So,
Yes. Yeah.
if you've got, I don't think you need to go and see your GP on day one or day two of developing symptoms, because the thing that differentiates inflammatory bowel disease from a gut infection or food poisoning is gut infections and food poisoning are self-limiting. They get better after 5 to 10 days. So I guess symptoms that that continue beyond 10 days to 2 weeks, those are the symptoms that you should go and see a doctor about. And absolutely, one of the key things is to try and get on top of the disease as early as you can to prevent gut damage, because once the damage has occurred, it's often very difficult to put time backwards.
Mm-hmm. Okay, brilliant. And are there any long-term complications that people should be aware of?
Yes, I mean, obviously, long-term complications aren't something to worry about until you've had the disease for some time. Sort of goes without saying. But I mean, people who have extensive active inflammation in their colon are slightly more likely to develop colon cancer. Only slightly, but slightly more likely. And we have a process by which we organise appropriate surveillance against that. Patients who have long-term Crohn's disease, often the disease can progress and cause scarring, which requires operations. And if you have too many operations, you can have not enough gut to keep your nutrition going, and so you may need some supplementary feeding. So definitely, that they're not conditions to leave active for the long term. They need to be appropriately managed.
Okay. So go along is the take-home message.
Yeah.
Go along, be investigated. Yeah. Okay.
Yeah, and just on that, if I might say, because often people think, oh gosh, investigation, that's going to require someone sticking something inside me. I don't want to have that done. There are some really nice, effectively screening tests that you can do. So blood tests and a poo test. And if those blood tests and poo tests are normal, that's really reassuring that you don't have inflammatory bowel disease. So just going to see your GP, you're not committing yourself to a camera test into your bottom. There are some very simple things they can do first of all.
Okay, so it takes me nicely to my next question. In that, if I did go along, if I did have symptoms and I went along to my doctor, what would I expect? And you've just told me that. So suppose you have the blood test and the poo test. Are they diagnostic or are they just suggestive? And then will you need further testing?
Yeah, great question. No, they are not diagnostic. They are just suggestive. Effectively, the blood test is showing inflammation in your blood and the poo test is showing inflammation in your poo. And if you've got inflammation in your blood or poo and you've got gut symptoms, then you need to be assessed for inflammatory bowel disease. And that requires the more detailed investigations. And yes, that does require a colonoscopy or a camera test into your bottom or a scan of your tummy. And you do need to have those done. So the initial tests that the GP would do aren't diagnostic, they're suggestive.
Okay, thank you very much. Okay. And moving on, so you've had your blood test, your poo test, you've gone along to someone like yourself, I guess, been investigated further, had your colonoscopy and biopsies, etc., whatever involves, and you are given this diagnosis.
Yep.
What conversation comes next? What are the management and treatment options that are likely to be discussed?
Yeah. So I think what I tend to do is, first of all, give a little bit of an explanation about what the disease is, and that's just what we've said. It's an immune reaction in the gut against the bacteria. And I talk through the fact that unfortunately, once you've got it, you've got it. It's not a curable condition in the sense that you can take a medicine and never have it again. It's a lifelong condition. Having said that, it's a lifelong condition that we're getting better and better at treating. And so I talk a little bit about the importance of not smoking if you've got Crohn's disease. And then I talk about what our treatment goals are. And I talk about that in terms of getting people better and keeping people better. Two different things. You've got to use something to get you better, and then you might have to take something to keep you better. And then I talk about what I mean by better, because better's a big thing. I mean, better is about not having gut symptoms, but better is also about healing the inflammation inside, even if it's not causing gut symptoms. So we talk about getting better in terms of symptoms, getting better in terms of the gut inflammation. And then better is also being able to do all the other things in life that you want to do, whatever they may be. So better is quite a broad term, but it's really important that we focus on getting people better and keeping people better.
Perfect, great. And can you give us an idea about how successful treatment can be and what factors influence success rates? So you've mentioned about smoking. Is
Yeah,
there anything else, for example, dietary or supplements, anything else people can do to maximize their benefit from treatment?
fine. Yeah. So I think I'm gonna answer. Can we park the diet question a little bit, because I think
Yeah,
that's a
sure.
really important question, and we'll come
Okay,
on to that maybe later. But
perfect.
in terms of alternatives apart from medication, stopping smoking, um, fair to say, pretty much after that you're onto some form of medication. There are limited other things that you can do that don't involve taking medicines, and maybe we'll talk about what medicines there are in just a bit. Other things
Hmm.
that that there is some evidence for, and people are understandably keen to take, non-medical routes if possible. There's some evidence for taking turmeric, curcumin, some evidence for fish oils, some evidence for aloe vera. But I think you should really be using those as supplements to medical treatment rather than alternatives, because the evidence that suggests that they are really, truly beneficial is quite patchy.
Right. Okay. And in terms of the medical treatment, are
Yeah.
these tablets or injections, or can you talk us a
So
little
it's
bit
a
through
whole
that?
range. Yeah, a whole
Just an
range.
idea.
So from a medical perspective, there are tablet-based treatments, and there are injection-based treatments, and which are injections you can give yourself, a bit like a diabetic pen, and then there are infusion-based treatments. And broadly speaking, I divide those into different categories. There are drugs that work locally, so effectively never get absorbed into the body. They're a bit like rubbing a cream onto a rash. You're taking something to rub on the surface of the gut to make it better. And you
Hmm.
can either give them by mouth or into the bottom as a suppository or an enema. And they're the sort of first line treatments for colitis. Other tablets are fast acting and broadly immune suppressing, and those are drugs like steroids. Very effective, but do have some side effects, and so we use them in very short bursts.
Yeah.
Um, and then the more longer term treatments are either tablet based or injection based immune suppressant drugs, which now are really engineered. They're really targeted. So rather than suppress lots of aspects of your immune system, they only are designed to suppress one single aspect, and therefore they can be quite effective whilst at the same time being quite safe. So there's a whole range of different medical options out there.
Okay. And in terms of success rates, if you're compliant on these
Yeah,
options?
I mean, I would say, we would hope with successful medical treatment to get 7 in 10 people better and keep them better.
Oh, that's wonderful.
70%. Now, of course, that might say, well, what happens to the other 30%? But in general, what you end up doing is you end up trying different treatments, different combinations of treatments, in order to properly get people better.
Okay, perfect. And side effects of treatment? Are there any? I mean, with a range of drugs, obviously there'll be a wide range of side effects, but any that you think deserve particular mention today?
Yeah, I mean, I think, it's fair to say that all drugs that suppress the immune system have side effects, because we have an immune
Yeah.
system for a reason. The immune system's there to help us fight off infections, and to be honest, to help us to prevent us developing cancers. And so those are obviously the side effects. Most of the drugs we use have a slight increased risk of infection, and most of the drugs we use slightly increase the risk of developing a cancer. But it's really important to get that risk in perspective. For the majority of our patients, who are young, fit, and otherwise healthy people, their background risk of getting either of those is so tiny, tiny, tiny small that if you increase that tiny, tiny, tiny risk, it's still a tiny risk. Whereas, yes, you can say something scary like, these drugs are going to make it twice as likely that you're going to get pneumonia.
Mm.
Well, that sounds horrid. But if your risk of getting pneumonia is so infinitesimally small that
Yeah.
double that is still small. So I think, as ever with risk, it's about getting risk in perspective.
Okay. And now, can you tell us a little bit about diet? you
Yeah.
mentioned before.
Diet is a really important thing, and absolutely understandably for patients, it's a critical thing. If you've got a disease that affects your gut and affects how you go for a poo, it's completely understandable to think that what you put in your mouth, what you eat, is going to affect your disease. And of course, that's absolutely true. So it is clearly a very important question. However, it's really important for both us as doctors, but also patients, to understand that there is an absolute difference between modifying your diet to improve the degree of inflammation, to use diet as a treatment for disease to get you better or keep you better. That is very different from using diet to reduce the symptoms of your otherwise ongoing disease. And it's really important that you get that we understand that. Just because someone cuts out wheat, cuts out dairy, cuts out coffee, and their symptoms get better, doesn't mean that wheat, dairy, and coffee are causes of the disease, or that cutting them out is a treatment for the disease. It just means that when you cut out foods that get fermented, you improve your symptoms. So that doesn't mean that it's not important. It's hugely important because it might make you feel better. It's just about not thinking that that can be the only thing. But there are some true dietary treatments. So particularly in children, there are special formula diets, sort of milkshake-based drinks that you can use as a complete treatment for the disease. No drugs whatsoever. You simply take the dietary strategy and that treats the disease. Sounds very straightforward, but you don't eat any food, so you're just taking these milkshakes. So it's quite challenging to do, but it avoids taking drugs. It avoids the negative effects of some of the drugs, particularly steroids, on growth and puberty if you're a kid, and therefore it's a great treatment. And we and others are looking to see whether there are more manageable dietary strategies that you can use to control the disease activity. So when a patient, patients often say, well, shall I modify my diet? I have that conversation. You've got to be very careful about differentiating, changing your diet and improving your symptoms, and changing your diet and improving your disease. But obviously, you can improve symptoms by modifying your diet. What I tend to advise people is not to do it until they've got better from the perspective of their inflammation. Because if you start modifying your diet at the same time as you start taking a treatment, you're going to get very confused about what's causing what, and you're not going to know whether it was the cutting out of this. So I like people to be stable, and then we take an assessment of what their symptoms are, and then we think about what we can do to try and improve those with diet.
Okay, great. Thank you. That's a really clear answer. So thank you for those clear and detailed answers to my questions. As you know, I ask listeners beforehand to submit questions that I ask on their behalf. Would you be happy to answer some questions that have been submitted? Brilliant, perfect.
Of course, if I know the answers.
Well, if you don't know. I must stress at this point that it is very difficult to give specific and personalised advice to patients without a thorough knowledge of their past and current medical history, examination findings, and investigation results. Also, due to time constraints, I have summarised the questions in such a way that I think retains the essence of what is being asked. Therefore, these answers should only be used as a guide, and individualised care and management should be sought from one's own doctor. Okay, so the first question is, I'd like to know, are we any closer to a cure? At the moment, the treatment plans carry so many unwanted side effects. So any new drugs in development that offer hope?
So there has been an absolute revolution in the number of new drugs available for treating inflammatory bowel disease. We had one new drug every 5 to 10 years when I started in this, and now we have 5 to 10 drugs every year being launched. Oh, wow. So there are a load of new drugs, and that's great because it gives people choices and it gives people options, and there are drugs that are more suitable for different types of people. And so there are many new drugs. The trouble is, each of the drugs that we have is only effective in a percentage of patients, and there is no drug that is effective in all patients. And although we understand so much more about the disease and what drives it and what we can do to improve it, we are no closer, I think, realistically, to being able to cure it. There is no cure for inflammatory bowel disease.
Okay. The next question is, I have Crohn's disease. What are the chances my 3 children will develop inflammatory bowel disease?
Yeah, it's a great question, and one we get asked all the time. As I said, I think a bit ago, sadly, one of the biggest risk factors for developing disease is having a relative who got disease. So your children do have a slightly higher risk of developing disease than someone who's not got disease as children. But it's really important to remember that that risk is still tiny. They're still far, far, far more likely not to develop disease than to develop disease. And in terms of what you might do to prevent them, obviously, you have to be a little bit careful about that. Obviously, not smoking would be a good thing if you've got Crohn's disease, and your children not smoking would be a good thing because that will reduce the risk. I think it's difficult to give evidence-based advice about anything else. My personal view, and I would caution that this isn't 100% evidence-based yet, is my personal view is that we'll find out that avoiding super processed foods, ultra processed foods, will be a good thing, but we're not quite there yet.
Okay, thank you. And just to clarify, so you mentioned a lot, I know you run an adolescent and adult service. In terms of the age that it is most likely to appear, that I guess there may be a range, but does it happen quite frequently in children and adolescents?
Absolutely, yeah. The peak age of onset is adolescence. So between the ages of 14 and 22 is the peak onset. Over 25% of people who get inflammatory bowel disease are diagnosed before their 18th birthday. So the majority of people are young people when they develop disease, either in childhood, late childhood, or early adulthood. There is actually a second, smaller peak in your 50s and 60s. So there are sort of 2 peaks, but the most common time is in adolescence. And that's why we have an adolescent IBD service, because the way that the healthcare system is structured is that you're under a pediatrician until you're 16, and then you go to an adult service, and they may not be in the same hospital. And that's actually the time that you're most likely to get this condition. So it's a time of risk. So we've created a clinic that spans that period of time so that patients feel there's a degree of consistency, a degree of continuity.
That's fantastic. And again, I guess that emphasizes the need to get in, be diagnosed early, because you're with it for a long time. If you get in adolescence, you've got a long time with this
Absolutely.
condition.
And of course, it's also a really important time of people's lives. They're developing themselves. They're becoming who they're going to be. They're going through puberty. They're having exams. They might be finding relationships, having sex for the first time, experimenting with this, that, and the other, going to university. There are loads of things happening, and you can imagine that, pooing a lot during a lot of that is actually quite a challenging time, and people are shy at that age. So it really is important to come and get it dealt with, because we can make it better.
Yeah, perfect. Great. So the next question is, can diet really help the progression of the disease? I've read so many conflicting articles, but I've seen a recent study that is looking at the effect of additives. Obviously, certain foods can affect symptoms, but are there any things we can cut out or add in that would affect the activity of the disease itself?
So that sort of comes back to what I was saying before.
What you were saying before.
There is no evidence really that any particular dietary strategy currently will change the natural history of the disease, apart from the taking the liquid drinks only diet that I talked about. It's actually our study. We're doing a trial of cutting out food additives as part of a treatment plan for Crohn's disease, but we're still running the study. And so I can't tell you yet whether it's going to be effective or not effective. That's a trial we're doing in 150 odd people with active disease. So yes, I'm very interested in that, but I don't know the answer yet.
Okay, something to look out for. Okay. So my next question is a bit of a long one. So I had 4 to 5 years of worsening abdominal pain, rectal bleeding, irregular periods, and inability to get pregnant. My GP referred me to gynecology and I was listed for laparoscopy to investigate endometriosis. I found out I was pregnant at the pre-assessment. 2 weeks after my second baby, so this is quite a gap between, I was admitted and diagnosed with moderate to severe ulcerative colitis. The doctor who diagnosed me said I would probably never had endometriosis or gynae issues and was always likely to be a bowel problem. The question is there a link between endometriosis and IBD, or are women often misdiagnosed with gynae problems?
So there's no link between endometriosis and IBD. They're not linked conditions. Obviously, they both can cause symptoms that are not dissimilar. The thing that, in my mind, distinguishes them is the symptoms of endometriosis are almost always, but not exclusively always, linked to your menstrual cycle. So they come and go with a regular period, with a regular period in between. Whereas inflammatory bowel disease is chronic. Obviously, it's not possible for me to comment, as you say, on an individual case to know whether there was or wasn't endometriosis there. I don't think I would ever know that. I think it's true to say that patients can come to a Crohn's disease diagnosis via a whole range of different other specialties, and it often is where you access healthcare first, obviously, is the type of symptoms that you're first investigating for. What I would say, though, is the stool test I was talking about, the fecal calprotectin, the poo test, that's very, very specific to your gut. So if you've got symptoms and your stool test is up, that won't be caused by anything else apart from gut inflammation. So it is quite a useful test, and it can be done by your GP. So before you start going down the route of gynecology or wherever with a set of symptoms, which may be very difficult to know where they're coming from, the poo test can be quite useful.
Yeah. Certainly this is right up my street as a gynecologist. I see many women who think they have endometriosis, and we may go down the line. And I always, as a starting point, unless it's really obvious, say, well, it could be bowel related, it could be gynecological.
Yeah.
Sometimes we do a laparoscopy, and I say, well, if there's no endometriosis, then that's the other outcome. So it's really good that you have, you agree.
Yeah, I definitely do.
Mm-hmm. Okay, so following on, is there a link between irregular periods and IBD?
Well, yes. No, not in the sense that IBD doesn't affect your menstrual cycle, except for the fact that if you've got very severe inflammatory bowel disease, you've lost a lot of weight, you are sick, you may notice that your periods reduce, and some people even notice that their periods completely stop. The diagnosis of Crohn's disease is one of the causes of delayed onset of periods. If you've got really sick because of Crohn's disease and you don't know it, you may not develop periods. Likewise, if we really successfully treat your disease, people suddenly develop periods and, interestingly, can suddenly obviously become pregnant. So it's not that there's a direct link apart from being sick.
Yeah, absolutely. Okay, and does inflammatory bowel disease affect fertility?
Well, the answer to that is yes and no, which is an awkward answer. Intrinsically, having inflammatory bowel disease shouldn't affect fertility. Obviously, for the same reason that it affects your periods, if you're really, really sick, you won't be having periods, you won't be getting pregnant. And if you're a guy, your sperm count will fall if you're really, really sick. The thing that affects fertility is having surgery for Crohn's disease or colitis. Surgery where you need to open up the abdomen and do something in the pelvis makes women less fertile and can give men a problem with getting erections and ejaculating. Interestingly, when you look at people with inflammatory bowel disease, they do have less children than people without inflammatory bowel disease. But not all of that is fertility. Some of it's fertility, and some of it's actually that they have, either through not having sex or through making a personal decision, they are less likely to have children. And I think one of the things that we need to do, because of course some of it might be doctors telling them that you can't have children, or that you can't have children on this drug or that drug. We need to reassure people that there is, pregnancy is an important part, obviously, of normal life, and it is our goal, our job as doctors looking after people with inflammatory bowel disease, to help them navigate through that successfully if we can.
Yeah, perfect. Yeah. Okay. Next question is, I stopped smoking and straight away my bowel symptoms got worse and worse. Is there a link between stopping smoking and IBD worsening?
Yes, if you've got ulcerative colitis. If you've got ulcerative colitis and you stop smoking, sadly, your disease will get worse, almost always. Actually, then the temptation, well, just start smoking again. But that's not really the right thing to do. The right thing to do is to treat the disease so that you can stop smoking without having a flare of your disease. And that's the way forward with that. But yes, there is a definite link.
Yeah, perfect, great. Okay, so back to pregnancy. I've got IBD and I'm planning to try for a baby. Is there a link between pregnancy and worsening IBD? So I guess, does pregnancy worsen the symptoms of IBD? Is that question?
Really important question. And again, obviously not all pregnancies are planned or can be planned, but if you've got inflammatory bowel disease, it's a really good idea to try and plan your pregnancy for several reasons. Firstly, from the perspective of becoming pregnant, you're much more likely to become pregnant if we control your disease properly. And so disease control is part of pregnancy planning. And if we control your disease, and if you enter pregnancy with your disease under control, you are highly unlikely to have a significant flare of your disease during pregnancy. So pregnancy doesn't make the disease worse, or the disease doesn't get worse during pregnancy, unless you've got nasty active disease when you start pregnancy, and then it can get really worse. Critically important is to talk about it with your doctor, because understandably, some people think, well, I'm on all these drugs, I want to become pregnant. What I'm going to do is stop my drugs because that will be better for the baby. That's the wrong way around. All the drugs we use, apart from some very, very rare exceptions, are safe in pregnancy. And it is much, much better to be on drugs, have your disease under control, and become pregnant, both in terms of the chances of getting pregnant, but also in terms of the outcome of that pregnancy, than it is to stop the drugs and have a flare of disease. Now, of course, there are some drugs that you cannot take when you're pregnant or trying to become pregnant, but it's something to talk to your doctor about.
Yeah, so this is one of the conditions where preconception counselling would be a good idea. Go along for planning pregnancy, go along beforehand, get all the information, and then make the right choice for you.
And lots of hospitals, or some hospitals, including ours, we run an IBD pregnancy clinic between one of us and our obstetricians, and to do exactly that, to do preconception counselling, talk about the appropriate vitamins, talk about planning pregnancy in terms of disease activity, and then talking about what to do with medication, what to do in terms of the route of delivery, very importantly with some of the drugs, what to do about vaccination in the newborn. But that's definitely something to run through with your IBD team.
Okay, perfect. Okay, the next question is there a test to find out if IBD is genetic?
That's a really interesting question. So, the simple answer is no, as in there's no test that you as a patient can do to work out what the relative contribution of genes versus environment is in your disease. As mentioned, it's a multifactorial disease. There are genetic risks and there are environmental risks. The trouble is, it's not like a disease, as I say, like cystic fibrosis or muscular dystrophy, where there's one gene that causes the disease, and therefore you can test for that gene, and if you've got it, you're going to get the disease or likely to get the disease. If you haven't, you're not. There are maybe 200 or 300 genes, each of which
Oh,
gives you a
wow.
tiny increased risk of developing the disease. But of course, lots of people will have those genes and not get the disease. So there's no clinically useful genetic test.
Okay, very interesting. Okay. Is there any possible way, I think I know the answer to this, is there any possible way to treat IBD naturally?
Well, I mean, I guess it. I mean, so when you think about treatment for inflammatory bowel disease, and what you may or may not need to do, I always liked in my mind to have an idea about what the prognosis of the disease is, what the natural history of that disease is going to be for that person.
Yeah.
And there are people for whom their disease is really mild. It's really good prognosis. You know from looking at them that they've not got much in the way of active disease. Their risk of the disease progressing and causing significant problems is very, very small. In which case, yes, I mean, there are, as I said, you can take curcumin, fish oils, vitamin D. Some probiotics have some evidence behind them, and all of those things are fine. You are sort of using alternative treatments in people for whom the risk, if they don't work and the disease remains active, is not great. But if you have significant disease, poor prognosis disease, no.
Okay. And question again, what is the percentage of your child developing IBD if the mother has it? We don't know. I think you've answered that already.
Yeah, so I mean, it's still of the order of a very few percent. So
Yeah, very small.
it's not a huge risk.
I think that'll be really, really reassuring. Yeah. Okay. Next, what is the best medicine or biologic to treat IBD?
There's no right answer to that. As in,
Mm-hmm.
we have 4, 5, now maybe even 6 different classes of biologic. They all work in different ways. They all target different pathways, and different drugs will be better for different people. And it will depend a little bit on how quickly you want the drug to work, a little bit about how long you want the drug to work for, a little bit about what other drugs you may or may not need to take with it, a little bit about what's gone on in that person's life beforehand. If they're older or younger, if they've previously had cancer or not, do they have lung disease, do they have heart disease? All of those factors are taken into consideration to decide what the best treatment for an individual is. So there's no one answer that this is the one you should start with for everyone. It's true to say that you want to make that decision, you want to get the best suited one for that person, but it won't always be the same for everyone.
Yeah. And I guess that's the benefit of going to a specialized clinic like your own, multidisciplinary care. The treatment can be personalized and individualized to the particular patient.
Absolutely. Although it's fair to say that pretty much every hospital within the UK will have an IBD team. I think IBD is frequent enough that pretty much every hospital will have a dedicated clinic, an IBD nurse, a doctor whose focus is predominantly looking after IBD.
Perfect, great. Okay, and the next question is, would you encourage a patient to have a drug holiday if they are feeling better?
So I think this is a really important question in terms of, we don't want to have people on long-term drugs. If you start a drug, are you going to be on it for the rest of your life? That's both in terms of, the impact on a patient's life, safety, but also in terms of cost to the healthcare system. So there's no absolutely right answer for everyone here. It is entirely reasonable, if you are completely well, to try coming off treatment and seeing what happens. But I mean by completely well, I mean absence of symptoms, but I also mean no evidence of disease activity on endoscopy or imaging or something like that. So it's not just about feeling well, it's about there being the disease truly being better, as I said at the beginning. And then I think it's entirely reasonable to come off drugs. What I normally tell people, all the data would suggest with the advanced therapies, with the biologics, if you come off medication, it's about a 50-50 chance. There's a 50% chance you'll stay well over the next 2 years and a 50% chance that you'll have a disease flare. And that's a sort of glass half full, glass half empty. Some people think, wow, that's amazing. There's a 50% chance I can come off medication. And the other people think, whoa, blimey, there's a 50% chance that I'm going to have a flare. So I think then with that information, people can make a personalized decision, depending on whether they're half glass full, half glass empty. And the one thing that I think is really important is that if you do come off medication in discussion with your doctor, which is, absolutely in some people the right thing to do, it's really sensible to come up with a strategy of preemptive monitoring so that you can catch the disease flare just as it begins, before it sort of takes over. And so if people are coming off drugs, what we tend to do is we tend to do a blood and a stool test maybe 2 or 3 months after they've stopped it, and then again 2 or 3 months after that. And if you begin to see things tailing off, getting more inflammation, you sort of know they're going to have to go back on treatment, and it's probably wise to restart it before it causes a significant bout of symptoms.
Okay. But certainly it shouldn't be something you do off your own back. It's something after discussion with your team, your medical team.
Yeah. That would be my view. Yes, definitely.
Yeah, perfect. Okay. And what is the latest treatment for IBD? So you've discussed that.
If you want the absolute latest treatment, last week, one of the new small molecules was licensed for Crohn's disease. It's called a JAK inhibitor. Doesn't matter what, but it's called Rinvoq is its trade name. Upadacitinib is its real name. And literally last week, for the first time, hasn't been approved by NICE yet, but likely will be. Well, I can't say likely will be. I don't know the answer to that, but NICE will be looking at it. NICE will be looking at it in the next few weeks as to whether it's going to be refunded. So there are, as I said, there are new drugs coming out for inflammatory bowel disease, either Crohn's or colitis, and they're going to be. If you look ahead, knowing what clinical trials are going on at the moment, we're going to have more and more drugs coming out, which is of course great in some ways. It gives people much more options, but it does require. There are more choices, and that's both a good thing and obviously, then you've got to make the right decision.
Yeah. Well, I have to say, you're painting a really bright future for patients, which is, really, really uplifting, actually. And the last listener question is, what does the future look like for IBD and getting patients diagnosed more quickly?
Yeah, so actually, if you think about it, and you've rightly looked at one end of the disease, which is all the exciting new treatments and all the potential options there are out there. But actually, I suspect in terms of the magnitude of benefit that will have for patients, actually each additional drug will probably give less and less additional benefit because we've got loads of drugs. Actually, I agree with the reader's question. If I was trying to make the biggest difference to the outcome of patients with inflammatory bowel disease in the UK at the moment, it would all be about how we get people diagnosed quicker, how we get them into the right clinics more efficiently, and get them on treatment earlier. And that actually, there's nothing clever about that in terms of clever drugs and clever processes. It's about systems. It's about making sure that people recognize symptoms. It's about them seeking early advice from their GP, the GP sending off the right test, acting on the result in terms of endoscopy. And then when a patient comes up to a big hospital like ours, they have an endoscopy and the endoscopy shows inflammatory bowel disease, being able to get into our clinic in the next couple of weeks. It's all about the process. And that's certainly something we're working on, and others are too, to try and get the disease under control. Can I just do a couple of shout outs while I'm here? We haven't mentioned the patient organisation, and I think it's really important to mention Crohn's and Colitis UK, which has been the patient organisation in the UK for inflammatory bowel disease for decades, and it's got a wealth of really useful information and help and support across a whole range of different areas in terms of explaining drugs, explaining the disease, also explaining, what benefits are available, et cetera, et cetera, et cetera. I really strongly recommend that if you need more information, that's a really good first place.
Perfect. So I will put a link to that in the show notes and on my podcast website as well. So it's an easy place for patients to find it.
Can I just mention one other thing, because it hasn't come up, and I just think it's really important to come up, and that's surgery. We haven't talked about surgery, and obviously, most people, if you ask them, do you want an operation for your inflammatory? Most people would say no. The last thing I want is to have a surgery, to have someone open me up and cut a bit of my gut out. And I think that's a completely understandable and appropriate reaction. No one wants their gut removed, particularly people are really worried about surgery which might end up in a stoma, a bag where your poo drains out into a bag on your tummy. People understandably are really worried about that. But I think we always should be having sensible and informed discussions, because in some people, a limited operation is the best way forward for their disease. So we should go away from thinking of you only do surgery when the medicines don't work. That's perhaps not healthy or appropriate. Now, of course, if none of the drugs work and there's nothing else you can do, surgery might be the only thing you do. But it shouldn't be diminished and left to that, just sort of almost like it's the treatment of last choice. Because in some people, it should actually, or could actually, be the treatment of first choice, the best thing to do. Some people will have an operation and they won't have their disease come back for years and years and years. And a limited laparoscopic resection of a little bit of your bowel near the appendix, very straightforward procedure. Some people might prefer it than taking 5 or 6 years worth of medication. And I'm not saying that surgery is the right thing. I'm just saying, there's a tendency, particularly for doctors, but also or patients, to say, no, I'm not going to do that. And I think it should be part of the equation. It should be part of the discussion, so that we're not forgetting it. Sorry, that I just felt we hadn't mentioned it, and we need to sort of be balanced.
Well said. Absolutely, really, really important point, actually, because I don't know if in my head I thought of surgery being that, running out of options sort of thing, or an emergency, because you can have emergency surgery, can't you?
Of course, and of course, surgery is always better as a planned procedure than an emergency procedure. Always.
Okay, perfect. And okay, so I have got one more question, and that's from me.
Okay.
And you have managed many, many patients in your career thus far with inflammatory bowel disease. If you had the opportunity to speak to people with this condition on a wide scale, what would you say to patients who either suspect they may have this condition or they've been diagnosed with inflammatory bowel disease?
I think the most important thing to say is to recognize that it's a scary diagnosis to have, and to understand that the impact of the disease on people can be quite wide-reaching, and it's not always a pleasant thing to discuss. So I guess one thing is recognizing the impact it has on patients. But the second and the most important message is get diagnosed, get to see a doctor, get treatment, because honestly, we can make people better. And because of the way our clinics are set up to help across a whole range of different areas in terms of the impact of the disease on your gut, but also on your diet, also on your mood. A lot of clinics have, and ours does, has a psychologist and a psychiatrist in, because we can help with so many aspects of your life. So it's not something to shut yourself away with. It's something to come and get help about.
Okay, perfect. Thank you. So in closing, James, I'd like to thank you so much for agreeing to come onto the show. Thank you for supporting my efforts at educating patients, because I couldn't agree with you more. Such a big part of these things is awareness and education as well, that really, really taps into earlier diagnosis, which can affect outcomes. Thank you for all the hard work you've done through the years for patients with this condition. And thank you for painting such a bright picture and educating us today about inflammatory bowel disease. Thank you so much.
Well, it's an absolute pleasure.
Thank you for listening. I hope you found it useful. Please keep your eyes and ears open for upcoming episodes. If you enjoyed this, please hit the like and subscribe buttons to raise awareness of this podcast.